During the next minutes, we will review the TFC injuries, especially the imaging of TFC injuries. I have no disclosures, and all the arthroscopic and surgical images of this presentation are from my friend Paco Piñal. We will review briefly the anatomy, especially the MRI anatomy of the TFC complex, and then the classification and imaging diagnosis of TFC complex injuries. Let's start with a brief review of the anatomy. Remember that the TFC complex is a several structure, and this is a name introduced by Palmer to describe a complex structure, the ulnar aspect of the wrist, including the TFC proper fibrocartilage with a triangular shape, and reinforced by the volar and dorsal radioulnar ligaments, especially important for the stabilization of the distal radioulnar joint, the volar ulnocarpal ligaments, ulnolunate and ulnotriquetral especially, and also is composed by the ulnomeniscal homologue, and also the subset of the extensor carpi ulnar tendon. For us, for radiologists, the most difficult aspect in the evaluation of TFC anatomy and injuries is the ulnar insertion. Remember that the ulnar insertion has two different bands, one distal inserted in the ulnar styloid, and one proximal and with a more vertical orientation that inserts in the fovea. This is the most important in terms of stability because it's the convergent point of insertion of the distal radioulnar ligaments and ulnocarpal ligaments. The stabilization of distal radioulnar joint and ulnocarpal joint is very important for this stabilization is very important, the ulnar insertion. And also we have another anatomic structure that is named ligamentum subchoroidum interposed between these two bands. And for us, for MRI, is a source of misdiagnosis as degenerative changes or tear. We should be aware of this variant of this anatomic structure interposed with a high signal in all MRI sequences, not should be interpreted as pathology. In the evaluation of TFC, it's very, very common that most of radiologists only pay attention to the coronal slices. Of course, they are the most important, the most informative plane for evaluation of TFC and all the carpal structure. But we need all the planes, and we need also 3D studies to make adapted reconstruction to this special adapted pathway of several structure of the wrist. This is a sagittal image, and we can see very nicely the TFC with the central TFC proper with a more thin and thickenings of the volar and dorsal radioulnar ligaments. Also, these sagittal images are very important to evaluate the capsular insertion, the dorsal and volar capsular insertion, and also to see the ulnocarpal ligaments. Like in this image, we can see the ulnotriquetral ligament from the insertion from the union with the volar radioulnar ligament to the volar insertion in the proximal aspect of the triquetrum. But also axial images are really important for a complete evaluation of the TFC and the wrist structures. Like in this case, we can see the normal volar and dorsal radioulnar ligaments, the central TFC, the insertion on the cartilage of the radial sigmoid notch, and also we can see the ulnar fovea, and especially important for the axial plane is very important to evaluate the extensor carpi ulnaris and extensor carpi ulnaris subset. Ulomeniscal homologue is a structure with several anatomical parts, radioulnar. The most important one is the styloid from the tip of the styloid to the dorsal aspect of the triquetrum, the collateral and distal insertion in the medial aspect of the hamate and base of the 5 metacarpal. Remember that the pathway of the ulomeniscal homologue is essentially deep to the extensor carpi ulnar tendon, with a close relationship with the subseat, with the seat of the extensor carpi ulnar tendon. And on MRI, we can see nicely the different parts of the ulomeniscal homologue. This is the triangular portion, the triangular portion inserted distally in the dorsal aspect of the triquetrum. This is the styloid portion, the collateral portion with a slight hyposignal related to the hyposignal of the extensor carpi ulnar tendon, and the insertion on the medial aspect of the hamate and the distal, the base of the 5 metacarpal. Also, we could have variation of the insertion of the styloid portion of the ulomeniscal homologue. We could have open insertion with only a small insertion in the dorsal aspect of the triquetrum, and we could have a cover ulomeniscal homologue inserted not only in the dorsal aspect of the triquetrum, but also in the triquetrum, the proximal aspect of the triquetrum, and even in the lunotriquetral ligament. This is a very really uncommon variant, but commonly associated with pathology. Remember the TFC anatomy and the vascular anatomy, and we have the TFC is vascularized by the ulnar artery and the palmar and dorsal branches of the interosseous artery. On MRI, we can see nicely these major arteries that vascularize the TFC, but the vascularization of the TFC itself is not possible to evaluate on MRI. It's a limitation, a significant limitation for the MRI in the evaluation of TFC. Let's move to the brief imaging review of the imaging diagnosis of TFC injuries. Commercial X-ray is usually the initial imaging evaluation of any wrist injury, and especially traumatic injuries. And this could be informative sometimes, but most of the cases is completely normal. We can see sometimes sign of distal radial joint instability, such as joint widening or misalignment. We can see also anatomic variants or fractures of the ulnar styloid or distal radius or other carpal bones. But also we can see the ulnocarpal impingement, the ulnar variants, and again in the right X-ray we can see ulnocarpal positive variants with the ulnocarpal impingement and secondary changes in the medial aspect of the lunate. This is a classic ulnocarpal impingement, nicely seen on a conventional X-ray. It's an advanced stages of this ulnocarpal impingement. But MRI is the method of choice in the complete evaluation of the TFC injuries and in the differential of other causes of ulnar wrist pain. Commonly, several causes could be associated. Not only TFC is the origin of the ulnar wrist pain. And sometimes it could be useful to perform CT or MR arthrography, but the indications are very, very limited and only for specific cases. MRI is, we have a lot of manufacturers and different equipments, but in general terms, we can we can say that it's really, really important to have a height N 1.5 magnet, or better, a 3 Tesla magnet, to have a high resolution and high quality studies. The study of the wrist is the most challenging of the musculoskeletal imaging, because we have the most complex structure with the difficult triads, and also it's for that we need a special high resolution, and we need to specific wrist coils. We need to perform a small follow view, no more than 8 centimeters for a conventional study of the wrist. We should have the possibility to have a slight thickness with high quality, less than 3 millimeters, usually less than 2 millimeters. And it's very important also to have isotropic 3D sequences to perform reconstruction adapted to a specific anatomical structure. And also it's important advanced sequences such as arthrography or neurography, for example. As important, even as important as the magnetic strength is to have a specific wrist coils. This is not we don't have very good studies with a knee coil or other not specific coils. We need the wrist coil. This is 3 different options to have a perfect study of the wrist and to evaluate TFC. A specific adapted to anatomy of the wrist, a specific coil with 8 to 16 channels, microcoils that are a racket shape, and this is a very, very good coils to perform studies of the TFC with field of views even less than 4 millimeters and with very high resolution. And also another option is multi-purpose flexible coils with a multi-channel, even 32 channels, and the quality of these coils that could be used also for the elbow and other structure is really, really as good as other options. But the position of the patient is also really important. The planification for me is essential. We could perform the studies in the coitus prono with the patient in Superman position, and this is uncomfortable for the patient, of course. But the quality of the studies is optimal because the coil is positioned in the isocenter of the magnet, and the relation between the noise and signal is optimal, and we have very good with a high resolution, spatial resolution images. Another option is to use specific wrist coils alongside the patient. This is very in supinous. This is very comfortable for the patient, but we have sometimes problem with this alignment of the patient. The first of all, the coil is not is far from the isocenter of the magnet, and we have less resolution. And usually the manufacturers say that this is the ideal position for the coil, but it's not true at all. This is the origin of a lot of positive and negative diagnosis of TFC injuries, false positive and false negative injuries of the TFC. In this position, the wrist is not in neutral position, is in supination with the ulnar styloid dorsally located. The extensor carpi ulnaris is in a false subluxation, is in a forced position, and the TFC is lax and is very difficult to evaluate. Like in this case, this is a complete normal patient with a normal ulnar insertion of the TFC, but there are several images that could be very similar to an injury, especially if we have fluid in the peristyloid recess, or the problem of the ligamentous supraventum could make us false misdiagnosis of ulnar styloid foveal or styloid insertion, ulnar tear of the TFC. This is a completely normal patient. This is a real common problem, and this is very difficult to evaluate the DFC with this position. In this position, what is the solution? The solution is very easy. To perform the study alongside the patient with the coil in horizontal position. In this position, we have a perfect orientation between ulnar styloid and radial styloid, and we have a very nice view of the TFC ulnar insertion, both styloid and foveal insertion. Even like in the right image, even in cases of fracture or pseudoarthrosis of the ulnar styloid, it's very easy to evaluate the foveal and styloid insertion on the ulna. Of course, the gold standard in the diagnosis and treatment is arthroscopy, but MRI is a very powerful surgical method in the evaluation of TFC injuries. We move to the classification of TFC. We use commonly the Palmer classification, a broadly accepted classification between radiologists and orthopedic and hand surgeons, and it's very easy and makes the differences locations and treatments of the injuries. We have Palmer class 1, Palmer class 1, traumatic injuries, and class 2 degenerative injuries. Palmer class 1 are also subdivided by location. Palmer class 1A is located in the central aspect of the TFC proper, respecting the volar and dorsal radioulnar ligaments. It's an unstable and very common injury. Another common injury is Palmer class 1B, with a variety of injuries affecting the ulnar insertion of the TFC. Palmer class 1C is described as a tear of the ulnocarpal ligaments on the carpus. This is a really uncommon injury. And also a not common injury, but very easy to diagnose on MRI, is the Palmer class 1D, with a different injuries of the ulnar, the radial insertion of the TFC on the insertion on the sigmoid cavity of the radius. This is a really common injury, the Palmer class 1A traumatic injury, and we can see in the coronal, the most important images to evaluate the TFC. We can see in the first image the normal dorsal radioulnar ligament. In the second and the third, we see a central tear of the TFC, and in the last image, we see the normal volar radioulnar ligament. This is a typical Palmer class 1A, but also we can evaluate this injury in other plans, like in the sagittal. We see the normal thickenings of the volar and dorsal radioulnar ligaments and the central tear of the TFC proper. And also in axial images, we see the normal distal radioulnar ligaments and a split tear of the central TFC and the arthroscopic correlation. Palmer class 1B is also a very common injury, and Paco Piñal described a classification of these injuries. We could have an injury of the styloid insertion, non-communicating injury, another non-communicating injury, very important in terms of stability of the distal radioulnar joint, especially the foveal insertion. We can have a complete disinsertion of the TFC from the ulnar insertion, but also it could be complicated by fracture or pseudoarthrosis of the ulnar styloid. making the diagnosis of this kind of injuries really challenging on MRI. And another very popular classification and useful classification is the ATSEI subclassification of Palmer class 1B. It's a classification considering the affected component of the TFC, the present or not of distal radial joint instability, and the healing potential of the injury. It's a very important classification in terms for recommendation of the treatment of each category. And this is a partial non-communicating tear at, say, class 3, affected the foveal insertion, the conjoint point of insertion of the distal radioulnar ligaments and unocarpal ligaments. This is an injury in a tennis player, and we can see on MRI very nicely the tear affecting only the foveal insertion and respecting the styloid insertion, a non-communicating injury. And also, this is very characteristic on axial images. We can evaluate an static subluxation, dorsal subluxation of the ulnar head. Is a static form of distal radioulnar joint instability. In these two cases, we have a very easy manner to evaluate the foveal insertion and this kind of injuries. Injection on the distal radioulnar joint only 1 millimeter of contrast nicely demonstrate the foveal injuries. In this case, this is a professional tennis player. This is maybe the reason of the MR arthrography. And this is a top 10 player, and we can see very nicely the detachment of the foveal insertion on T1 and T1 FATSAT MR images, but the styloid insertion is respected with any communication without contrast in the radiocarpal compartment. And this is another partial communicating injury, in this case affecting the styloid insertion and associated with an acute fracture or the ulnar styloid. Even in case of fracture, we can evaluate very well, like in this case, that the foveal insertion is respected. It's a stable injury, and this is, in this case, was treated with a capsular attachment, and this is very easy to make this diagnosis on MRI. And this is another case on MR arthrography, and we see the tear affecting only the styloid insertion, but respecting the foveal one. More difficult in cases of pseudoarthrosis or fracture of the ulnar styloid, we need especially a very good MRI exam. It's really difficult or impossible with a not optimal MRI to reach an appropriate diagnosis. Like in this case, this is an all 1.5 MR image, and it's really difficult to be confident of the status of the foveal insertion. But with a normal MRI or 3 Teslas, very well positioned, a small follow view, like in this case, is very clear that the foveal and styloid intersection are respected in this patient. This is a complete injury of the Palmer class 1B type 2 of ATSEI, affecting both the styloid and foveal insertions. And in this case, it's very easy to make the diagnosis on MRI, and also we can see on axial images a marked dorsal subluxation of the ulnar head, a marked static distal radioulnar joint instability. And this is the arthroscopic correlation. This is a case of Paco Piñal. What are the limits of the main limits of the MR of the imaging, and especially the MR imaging in the evaluation of the Palmer class 1B injuries? is to demonstrate the difference between the class 2 well vascularized and potential reparable injury from a vascularized peripheral chronic injury, not possible to repair because the vascular status is not good. And this we could have some indirect sign, like in this case, we have in this irreparable injury at arthroscopy, we could have a marked retraction, thickening of the TFC, but the real, the final demonstration of the capacity of to differentiate between reparable or not reparable is only possible at arthroscopy. Palmar class 1C are really uncommon injuries, and it's also very easy to identify on MRI. We see on coronal and sagittal a complete tear of the ulnocarpal ligaments, and in this is another case on MR arthrography, the detachment with a ligament stump is very clear on imaging. Another variant of Palmar class 1C is a longitudinal split of the nototriquetral ligament. This is usually secondary to trauma with varus extension and forearm supination, and is a patient with a chronic ulnar wrist pain. And on MRI, we see the ulnotriquetral ligament with a dorsal degenerative changes, distal degenerative changes, and a split near the triquetrum insertion. It's very easy to see both in coronal, in sagittal, and also in axial images. Palmar class 1D was described initially by Palmar as a complete detachment of the TFC from the radius, but arthroscopic examination shows us that this is not a common injury. It's most common to have another minor variants. The most common variant of the Palmar class 1D is a tear affecting only the insertion of the TFC proper on the radius. Also, we could have a tear associated of the TFC proper with the dorsal or volar radial ligaments, or even with fractures, especially in the dorsal aspect of the radial sigmoid notch. And the complete detachment is less common. This is the most common variant of Palmar class 1D. It's very similar to in terms of treatment of the Palmar class 1A. We see abnormal dorsal radioulnar ligaments in the first image, coronal image. Second coronal image, we see the detachment of the TFC proper from the cartilage of the radius. And in the third image, we see the normal volar radioulnar ligaments. And also, we can nicely demonstrate this injury in the axial image. We see the normal volar and dorsal radioulnar ligaments and the detachment of the TFC from the radius. This is another example with a complete tear of another variant with a complete tear of the TFC on the radial insertion. And in this case, we have a marked instability at the development test, indicating a complete rupture of the radial insertion on the TFC. We move to degenerative injuries. These degenerative injuries of the TFC are really common. And remember that it's really common to have asymptomatic injuries. It's a very common finding in our MRI studies, and commonly we need to correlate the findings with the clinical examination because commonly are completely asymptomatic. More than 40% of patients are completely asymptomatic. The degenerative injuries usually occur in patients with positive ulnar variants, and it's part of the ulnocarpal impaction syndrome, with a progressive degenerative changes between the ulnar head, TFC, and ulnar carpus. Ulnar variance is an important measure to perform X-ray, and usually ulnocarpal impingement is related to positive ulnar variance. But remember that variance is a static definition, but the risk is not a static structure. This is my race, and this is a paper for a long time ago, and we can see I have a slight positive ulnar variance, but along wide space for the TFC. But if I perform the X-ray in making a fist, we can have a completely different findings. We see a marked positive ulnar variance and a significant reduction of the lunate space. Maybe it's the cause that I have a unocarpal impatient after playing tennis. This is the classification of class 2 of Palmer related to unocarpal impatient. The degenerative injuries usually starts at the proximal distal radioulnar aspect of the TFC. In the stage 2A is only debridement and only irregularities and thinning of the TFC. In stage 2B with more thinning and chondromalacia on the ulnar head. Stage 2C with perforation of the central TFC, Palmer class 2D with associated lunotriquetral tear and instability, and finally diffuse carpal arthrosis. On MRI, this is a common diagnosis, but remember once again, it could be asymptomatic. This is a Palmer class 2B with irregularities on the proximal aspect of the TFC and chondromalacia, a focal cartilage defect on the ulnar head. This is a typical, in this case, very symptomatic Palmer class 2C with extensive perforation on the central TFC and secondary chondromalacia and secondary changes on the ulnar aspect of the lunate with subchondral cysts and sclerosis. And it's for us another challenging diagnosis is to differentiate between Palmer class 2C and Palmer's class 2D. And the treatment, you know, is completely different. It's a really important differentiation. In this case, we have a complete tear of the lunotriquetral ligament. For this diagnosis, is useful to have 3D sequences or axial or oblique images adapted to the lunotriquetral joint. It's important because the treatment usually is completely different. Arthroscopic warfare procedure for Palmer class 2C or other treatments such as ulnar shuntoning osteotomy for Palmer class 1D. But in the last year, we have see that it's really common to have injuries not clearly included in the original Palmer classification. We have named these injuries non-Palmer. Non-Palmer injuries, we have systematized these injuries in central lesions, very similar to the degenerative injuries of the TFC and treated usually with debridement or warfare procedure, associated warfare procedures. Peripheral injuries that usually affect the well-vascularized part of the TFC are treated with debridement, reconstruction, and finally combined injuries with a combination of traumatic or degenerative injuries or intra-articular injuries that makes the treatment really important to have a very good surgical diagnosis. This is an example of the central degenerative injuries of the TFC not included in Palmer classification. This is a horizontal or flap injury, very similar to the horizontal tears of the meniscus of the knee. And usually it's not uncommon to have, like in the knee, parameniscal cysts, or in this case, adjacent cysts to the TFC. This is the arthroscopic correlation with the flap, horizontal flap of the TFC. These flaps could be unfolded and making the this injury very similar to the back and handle injuries of the knee also. And these back and handle injuries of the TFC are not uncommon, and we could have, like in this case, the back and handle affecting the proximal aspect of the TFC, very clearly seen on the conventional arthroscopy at the using radiocarpal portals. But in this case, it's a very nice case with a previous arthroscopy with normal TFC, and we have permanent pain and pronosupination and mechanical symptoms, and we can see a flap of the proximal distal radioulnar aspect of the TFC hanging in the distal radioulnar joint space, making the clinic of this patient. This is very easy to evaluate from the distal radioulnar joint on distal radioulnar joint arthroscopy, but most of the in our country, most of the arthroscopic are performed with radial, radiocarpal and midcarpal compartments, and this is a very good diagnosis on MRI. And we could have also peripheral non-palmar tears described the most common described by Paco Piñal or systematized by Paco Piñal in dorsal or volar detachment of the TFC from the dorsal or volar capsule respectively, and also including the Nishikawa lesion, that this is a carpal detachment of the unocarpal ligaments and meniscus homologue from the dorsal of the trichetrum. The most common of these of non-palmar injuries is the dorsal detachment of the TFC. This is a peripheral, very well-known injury that is really common, but I think most of the radiologists don't know very well this injury, but this very common injury. It's very easy to see the focal synovitis adjacent to the extensor carpulnar tendon, but the most useful plan is the sagittal, showing like in this central image, we see the dorsal detachment of the TFC. And remember that on MRI, focal synovitis, focal edema are usually secondary sign pinpointing the origin of the pain and the problem. Like in this case, this is another example of dorsal detachment of the TFC, very well described in this fantastic paper. And we see on axial focal synovitis, dorsal coronal image. We can see the capsular tear, but especially is well shown on these consecutive sagittal images, the normal central TFC, the normal volar and dorsal radioulnar ligaments, but detached the dorsal radioulnar ligament from the dorsal capsule. And this is the arthroscopic correlation of Paco Piñal with a normal central TFC, but a marked dorsal synovitis and a clear detachment of the dorsal radioulnar ligament from the dorsal capsule. The volar detachment is much less common. These are really uncommon injury. This is an example, and always remember that on MRI, the focal synovitis usually pinpoints the origin of the problem. Once again, this is a volar detachment of the TFC, or really uncommon injury. Another injury not as uncommon that's the volar detachment is the Nishikawa injury. Nishikawa describes a detachment of the meniscus homologue and ulnar capsule from the dorsal aspect of the trichetrum, and this is an example of ulnar detachment. So in focal synovitis is a very common finding both in MRI and arthroscopy, the regularity and detachment on sagittal image from the dorsal aspect of the trichetrum of the ulnomeniscal homologue and capsule. And this is not very well known injury for most of radiologists, and it's not uncommon. This is arthroscopic correlation, and another common finding on MRI and arthroscopy is a dorsal delamination in the dorsal aspect of the triquetrum. And this is another case, and we can see the dorsal detachment in the coronal and sagittal images with focal bone marrow edema and focal synovitis. Focal synovitis and fibrosis in the dorsal aspect of the ulnocarpal joint is a really common, really common finding associated with this injury. And finally, we could have complex or combined injuries. We could have this injury described by Del Piñal and Nakamura, associating central perforation of the TFC, at the degenerative injury of the TFC, associated with a traumatic division of the ulnar insertion of the volar and dorsal radioulnar ligaments, making this patient with to have a distal radioulnar joint instability. The treatment was a warfare procedure, a combining warfare procedure and reattachment of the ulnar insertion of the both distal radioulnar ligaments. And we could have a combination of traumatic and degenerative injuries very commonly. Like in this case, we have an all traumatic Palmer class 1A injury affecting the TFC proper, and acute tear, complete disinsertion of the TFC from the ulnar styloid and ulnar fovea with secondary distal radioulnar joint instability. In axial images, we see the two linear images representing these two points of tear of the TFC associated the combination of two types of injuries, Palmer class 1A and Palmer class 1B. This is another combined injury affecting the styloid insertion of the TFC in the coronal image. The foveal insertion is respected, but we have also associated a dorsal capsular detachment of the TFC and a radial tear of the subseat of the extensor carpi ulnaris tendon with the static subluxation of the tendon. This is really important to make a precise preparative diagnosis to avoid under treatment of these injuries. As a conclusion, remember that the recent advances in arthroscopic and imaging diagnosis have changed our understanding, our knowledge of TFC injuries. And MR provides an accurate diagnosis of most TFC injuries, but we need very good MRI equipment, ideally 3 Teslas, specific risk coils, well positioned of the patient, with a small field of view, thickness of less than 3 millimeters, ideally less than 2 millimeters. We need to have 3D sequences, and we need to have also musculoskeletal specialized radiologists on wrist. And MR orthography is indicated only in the useful cases of MRI, especially to differentiate, to have a precise diagnosis of Palmer class 1B foveal non-communicating at say class 3, and also is possible in selected cases to differentiate between Palmer's class 2C and 2D, as is, to demonstrate if the ulnotriquetral ligament is torn or not. Finally, remember, this is Santillana del Mar in Cantabria, in my town in Spain. A long time ago, we are interested in the paintings and also in the wrist imaging. And as Pablo Picasso said, after Altamira, all is decadence in painting, but also I think is decadence also in imaging of the wrist. Thank you so much for your attention.